type of thing. It's got
Welcome for the breakout session today. Our speaker is going to be Steve Koral. Update on biocompatible endodontics. Steve is a graduate of Harvard Dental School, 1980, magna cum laude. Practices in Boulder, Colorado. He joined the IAOMT in 1990, chair of the endodontic committee as well as the cyber committee. He has been on the board of directors for many years, and he's our incoming president, so we congratulate him on that. And Steve, take it away.
If anybody hadn't heard the talk that I gave in 2005 in Kansas City, an hour and a half of really running down the problems and issues with endodontics and so forth. That's the lecture, which you can get on the IAOMT online store. You know, just get the tape of that lecture because it's got the whole problem. It's got the overview of the root canal controversy, and as people in this academy are well aware, there is a lot of controversy about root canals. People in the so-called real world think it's greatest thing since amalgam. So, but we know the problem with root canals is the persistence of bacterial populations in the microscopic tubules. That's the primary thing. Anybody can slam some gutta percha into a canal, you know, rinse it out with hypochlorite, slam some gutta percha, get the overt infection to go away, get the person to quit hurting, and it's comfortable, it's functional, it looks good on an x-ray, good enough. And we know that it really is not good enough. So in an attempt to be biocompatible in our dentistry and keep teeth, we have to assume a responsibility, at least to attempt to treat the tubules, to treat the infections that remain in the tubules. So the primary method that dentistry has come up with in the last half a century has been to get away from using an inert plug, a cork, in the canals and try to add a disinfecting active ingredient. Calcium oxide, the French paste, has been the primary alternative for people who would like to try to disinfect the tubules. Okay, so you know, calcium oxide was Biocalex. Biocalex was the product that was made in France for many years by SPAD Laboratories. In about 2000, 2001, I think it was, SPAD Laboratories was acquired by Dentsply, and the first thing Dentsply did was kill Biocalex, take it off the market. By some quirk of fate, Guy Duquet in Montreal was in the process of cooking up a competing product. So he had, within a few months, he had it up and running, and it was essentially the exact same formula as Biocalex, and he calls it Endocal 10. Now, so we were able, after a few months, to get calcium oxide root filling again. But his company was Biodent. Biodent was a distributor of dental materials in Canada that Guy ran, and it just drained him of resources and drove him crazy, and he finally put it out of its misery this past year. But he kept Endocal 10. Endocal 10 is Guy's good friend is Alain. What's Alain's last name? Alain, I can't remember. Who is a chemist and he's a cosmetics manufacturer. But he's a chemist and he has a manufacturing facility, and they put together this little company called Albuca, which must mean something in French, I don't know. But Albuca is the manufacturer of Endocal 10, and now it's the source. So those of us who were getting Endocal from from Biodent. Now we get it from Albuca, and they actually can order it on the website, because you're better off ordering it on the website, because frequently you get somebody on the phone who just doesn't speak English. But it's fully available, and that's where you get it. I tell people I use a different technique for root canals, and I use something called calcium oxide. Yeah, well, does it work? Is the first question anybody asks. I mean, this is a question that we all want to know, and of course it works. There's a few problems. The biggest problem, of course, was the lack of radio-opacity. I mean, if you remember using Biocompatible down the years, the biggest fear was that somebody else would look at your x-rays. Because if somebody else looked at your x-rays, they'd say, you're nuts, you never did a root canal, you can't see it. So here's one. I don't have a pointer, do I? In any case, tooth number 19 over there, the molar. This was the very first case I ever did. This was a retreatment. And it was a woman who had a recurrent infection in that tooth. It had been treated previously. And you can still see a little remnant of gutta percha in those canals. But I retreated the tooth, and I filled it with Biocompatible. And it worked great. That was 1994. I think this x-ray was taken in 2004, and the tooth is still doing fine clinically. But you can't see the root filling. So that's the problem, you know. I mean, it's fine as long as she stays in my practice, but if she ever moves, somebody's going to take an x-ray there, and they'll never know she had a treatment. Okay, so the solution that I came up with over the years was I added stuff to the Biocompatible. I added barium glass at one point, and it was okay. I added bismuth oxide. Bismuth oxide is basically non-toxic, but it has, and it's very radiopaque, but it has this, oh, thank you. It has this alarming property of turning teeth black, so that was no good. And then I got some barium sulfate. Barium sulfate is what's used in gutta percha. It's used in a lot of different dental products, and it works great. You can really see it on X-rays, but there was enough objection among holistic dentists that they didn't want to use any barium stuff. So I kept looking. I came up with yttrium oxide, and I was inspired because heliomolar radiopaque has ytterbium trifluoride, hexafluoride. Anyway, I misread it. I misread ytterbium, and I thought I was reading yttrium. And I went and I got some yttrium oxide, which is a common chemical. You just got it from a chemical supplier. And lo and behold, it works really nicely. It looks like a microfill composite when you mix this stuff in with endocaltan or with Biocompatible. And then, luckily, a patient of mine is a medical director for a poison control center. So he's a well-placed toxicologist, gets me all the literature. And yttrium has an essentially clean bill of health when it comes to toxicology. So I started using that. And the other thing is that if you look in the, the original formula for Biocompatible was calcium oxide and zinc oxide. And then the original instructions were, well, if you could instrument the whole length of the canal, if you could get the whole canal accessed, you could put a little extra zinc oxide in there, and they thought maybe that would limit spatial expansion of the calcium oxide. So the chemistry of yttrium oxide is just about identical to zinc oxide. It's insoluble in an alkaline environment, and Well, it's worked great. So this is what it looks like. So number 30 over here is an older gutta-percha filling. Number 31 is calcium oxide mixed with a little bit of yttrium oxide. And so suddenly you can prove to another dentist that you actually did a root canal. What I'm doing is I'm mixing 2/3 of endocal and 1/3 of yttrium oxide. And that's how it looks, just like that. Where do you get it?
Steve Koral.
You know, I actually did all the paperwork for it and got it FDA approved, which I thought was probably helpful. And when were we in Calgary? It was 5 years ago?
5 years ago.
I handed all the paperwork to Guy Duquet and said, here it is, it's approved, go do it, and he hasn't done it yet. So yttrium oxide has been a kind of a little cult thing that I've been running, and the only source of yttrium oxide, if you don't have an account with a chemical supplier, is me. And I've been the dealer for a select few, like Greg and Ronnie. And, so far you can only get, Sonny, you can only get it from me. And I'm happy to send you some if you want to use it. But Albuca, Guy tells me that they have to recertify their products this coming year. They're going through a whole recertification process in Canada. And they will add the yttrium sometime next spring. So I'll be out of business, and it'll be great. But if anybody wants some, just give me a card. I'll send you some. Now, what are the problems? Lack of radiopacity. Okay, here is the bugaboo. When the original papers were translated from French to English, there was a word that was translated as expansion. And if I were translating it, I would have said penetration. But because it was translated as expansion, everybody immediately thought that meant it's going to crack the roots. And there's no literature on it until this fellow Goldberg, who was obviously an endo graduate student doing his master's thesis, and they had to find some topic for him, so they said, well, here, try this stuff, you know. So he took 15 extracted lower incisors and prepared the roots, prepared the canals, filled them with endocal 10, and as instructed, kept them in a humidor, and then examined them under a microscope. And he said that after a week, 3 of them showed evidence of fracturing. And therefore, the whole endodontic profession believes that 20% of roots filled with endocal 10 are going to fracture. All based on this little science fair project. So, and that has much more weight than decades of clinical experience, of course. Now, if you take an extracted root and you fill it with endocal and you leave it on the bench, it's going to desiccate and it's going to flake apart like a peanut because calcium oxide is extremely hygroscopic. I don't believe that a humidor provides enough water to fill the needs of the calcium oxide. So in any case, that's what we're dealing with. We're dealing with the vast amount of information included in this thesis. And we know, those of us who have used this stuff, there are no excess root fractures in real life. Am I right?
Absolutely.
Okay. Well, I organized a little study. I thought we should just do a prospective clinical follow-up study. And between 2001 and 2005, 4 of us submitted cases to this thing. Sonny was one. Janet submitted a couple of cases, and who was it in Calgary? Can't remember the guy's name. Not Evans, his former partner. Can't remember his name. Anyway, we put together 79 cases. And the cases were just teeth treated by, you know, teeth that had root canal treatments using Endocal as the filling material. I got everybody the yttrium oxide so you could see it. And the criterion was if you had a successful initial treatment, in other words, if you didn't break the files off, if you got the full length of the canals, if you felt like you got the initial treatment done right, submit the case, and then we followed them up. And at 3 years, there were 53 available for follow-up. And the results were, well, the criteria for results were relatively stringent. It was the classic. It was feels good, functions, looks good on an x-ray. And of these cases, some of them had persistence of the periapical lesion, so we called them failures. But only 1 tooth was extracted out of the whole 53 that were available to follow up.
Anterior or posterior?
Everything.
No, I'm talking about the extract, the 1 tooth.
Oh, the extraction. Now, this is a little bit of a story because, and that gives us our 98% retained in function figure, it fractured a week after the treatment, and it never felt better. So, and this was one of my cases. So I think it was previously fractured. I think it was a fractured root to start with. I mean, it wasn't something that felt good for 8 months and then felt bad. It was something that never felt good and fractured within a week.
What tooth?
19. Okay, now this is identical to the endodontic literature. In other words, you look at all the papers that were ever written on root canal success rate, and this is just the same. So nobody wants to publish it. It's been rejected by JOE. It's been rejected by International Endo Journal because we didn't have a control group, because it isn't a randomized controlled study. It's too observational. So I don't know. I'm going to resubmit it to maybe some less discerning journals, or I don't know what. So far, it's not being published, but you should know that there's no difference in clinical success between using Endocal and using other methods of filling root canals. David?
That's a higher success rate if you're going by radiographic appearance.
It is. It's a high success rate because my cases are done good. This is comparable to the, if you separate general dentists from endodontists, this is comparable to the endodontist success rate.
What exactly didn't you do right then to be submitted, to have it submitted? So
We didn't randomly assign patients to either Endocal or a gutta-percha group. As far as I can tell, that was the main thing. It's clinical observation rather than an experiment.
okay.
But clinically observing over decades, that's what you get. Okay, let's see. Another objection to using Endocal is that the liquid that is provided is ethylene glycol, which was the original formula from France in the 1960s. The point is that you want to limit the amount of water that's immediately available so that you don't get a physical expansion. And ethylene glycol is it's 80% ethylene glycol. And my toxicologist friend says, yeah, ethylene glycol has a metabolic pathway that leads to methanol production, which is why it's potentially toxic. He says, how much do you use? You know, I showed him like the little, he says, pfft. He says, we wouldn't bother with that. But, you know, we deal with a population of highly chemically sensitive patients, and some of them know all about glycols. And so most of the time I'm using the ethylene glycol. And who is it? Jerry Smith in Pennsylvania is very much against using this stuff because of the glycol, you know, and you got to respect him. He's a brilliant dentist and a brilliant, highly discriminating, holistic dentist. So, what's that? I'm getting to glycerin. My toxicologist friend says, well, why don't you use propylene glycol? And then my chemically sensitive patient said, glycol's no good, you know, it's going to go to the liver, it's going to hurt me. So we did. We brought up glycerin. And glycerin is similar enough, and it is also limited in water. It's it's less water. The thing about glycerin is that it's too cheap to be a dental material. That's about 40 cents, or I don't know, maybe it's up to 59 cents. And there's a lot of it. It's 4 ounces for that. So that little bottle is going to last me the rest of my career.
It's like acid ash.
Yeah, right. That's right. I've used it enough to know that it does work. I haven't used it enough to Greg, have you used it much? No. Did you try it? Because we talked about that. It works. Have you been using it? Yeah. Yeah. It has a slightly different consistency than the ethylene glycol, but it does work, and 2 weeks later the fillings are hard. And so I think we have an answer to the objection that we're using poison antifreeze.
Any comments from your chemist as far as the glycerin?
No. Well, there's a few new things, you know, just in terms of endo in general. I got interested in these new twisted files because they have everybody else's nickel titanium files are ground, and these are a straight wire that's twisted, so they claim that the structure of the metal is tougher and they'll break less. So I got a few of them, and I'm not sure. I probably have to go listen to somebody and learn how to use them better. One problem with them, here's a couple of these twisted files. They all have a 25 apex, and then they vary by taper. And so they always have a very skinny end in the canal preparation. This is a .04 taper profile from Tulsa, and it's kind of barrel-shaped. But it's much more similar to a lentulo spiral. So for the moment, I'm sticking with the .04 taper files because you have to prepare the canal in such a way that you can get a lentulo spiral to your working length. You know, otherwise you don't get a picture-perfect fill. And if you don't have a picture-perfect fill, you didn't do a root canal, and you're, you know. But so I've used these, and so far I'm sticking with them. Then what else? Let's see. Waterlays. Does anybody have a waterlays? Any? Okay. Yeah, it's a couple of people. I don't know. I always like to think of myself as a technology leader, so I went right out and got a Waterlays MD a few years ago, and I don't think I would do it again because I can't make it do what it's supposed to do, and except for endo. because last year they came out with these new tips. Radially firing tip. In other words, the problem with lasers always was that the energy comes flying straight out the end of the tip, and then you kind of try to go like that to point it at the canal walls, you know, down there an inch away, and you never know. But now they have these radially firing tips. Here's the cartoon. This is their cartoon of what it does. But they have these zirconia fiber tips that are polished, and the energy really does go out and aims at the side walls of the tooth. Now, I don't know if I'd buy a water lathe for this purpose unless maybe I were an endodontist doing this all day long. It actually, you can see it. This is the standard straight tube, and the red is the tracking light. In other words, the energy that comes out of this thing is in the far infrared, but they have a red tracking light. And this is the standard tip. It illuminates the whole root, and this is the radially firing tip, and you can see there's this band where it's concentrated. So it really does what it says it's going to do, which is shoot a laterally firing spray. And there were a couple of slides ago. There were a couple of papers published in the July 2007 ADA journal, which did show if you put enough energy from this thing into a prepared root, it'll kill a lot of germs. So that was good. You know, a relatively effective tubule disinfection. Although the energies they were using in those extracted roots, I can tell you from personal experience, it would hurt. So there's going to be some middle ground here. But in any case, a new thing in endo, documented tubule disinfection using a laser. So we're kind of coming to a point here. I mean, do you need a laser to do good endo? What's good endo? You know, we don't at the moment have a way to measure in vivo how profoundly we're disinfecting. We don't have a good way to measure in vivo how profoundly we're keeping it disinfected over time. And you know, I think there's an asymptote we're all trying to climb. Endo or no endo is a much higher stakes question than mercury or no mercury, because there's no question about mercury anymore. You can do every bit as good dentistry without it. But if you don't do endo, you're pulling teeth, and that's, you know, we all know that. Now, on the subject of can we keep them killed, how do you measure your success in vivo in terms of toxicity of the root? You know, there's that method of determining whether a tooth was toxic after you've extracted it by sending it down to Boyd Haley and the University of Kentucky, you know, to his photo labeling lab, and you can get a reading on how enzyme toxic the tooth used to be. But before you extract it, we don't have a really good method. We have the Topaz test. Are they here? Are they exhibiting? They're not exhibiting at this meeting. Okay, well, next time, I suppose. But does anybody not know what I'm talking about? Topaz test? Okay. The Topaz test was developed and improved over the last 10 years as a clinical colorimetric test for two things. One was sulfide toxins, and two, protein, total protein. So it's done with a microbrush. You take a gingival crevicular fluid sample, and you run it through these reagents, and there's a colorimeter that gives you the results. The idea is If you're finding sulfide toxins, then you know you have a bacterial load. If you're finding proteins, you know you have an inflamed site. And it's proposed as a method and you always do it relative to a control site in the same mouth. So it's proposed as a method for tracking, for following up on toxicity of a root, but it's never really been validated. I mean, it's never really been compared to the post-extraction numbers. So if anybody is in the business of extracting a lot of root canal teeth and sending them to Boyd Haley's lab for analysis, please contact me, because what we really need to do is we need to organize a little study where we do a pre-extraction topaz test, and then you extract the tooth and go through the rest of it, and so we can correlate the numbers and get an idea of how predictive the topaz test is for a more thorough measure of toxicity in a root. And Penty, if there are people at the holistic meeting in 2 weeks who are into that practice, let them know that I want to do this. Okay?
The problems with the validity of the chair side topaz test and being positives.
Yeah, I don't know. I honestly don't know. Now, I didn't get the Topaz 3, so I haven't been using it. I used the Topaz 2 for a while, but I haven't in a few years.
Was there any explanation for why controls often have the same toxicity as the?
Yeah, because especially in the sulfide test, because it's soluble, it's mobile. It's pretty well everywhere. It's not a localizing kind of test, but Boyd always talked about the protein assay being the localizing, the localizing test, because they don't migrate around as easily. Okay, well, so this is a matter of conjecture. This is a matter of future research. So. Just in conclusion, I think that what we're trying to do is we're trying to climb a hill of disinfection. We'll probably never get back to health when you have a dead tooth. Let's be realistic. But everything you do, everything we know how to throw at these germs is probably getting us a little closer. So if you think of, standard one-visit endo where you rinse it out with hypochlorite and slam some gutta percha in there, and then add a calcium hydroxide treatment dressing. You probably get a little better disinfection of that dentin by doing 2 visits. And
Are you mixing calcium hydroxide with glycerin or calcium oxide?
calcium oxide with glycerin is the final filling. That's the stuff that hardens up. Calcium hydroxide will never harden, but it's useful as a treatment dressing. There's a ton of literature about whether it's better to use calcium hydroxide or just do it in one visit, and the opinions go back and forth like the tides. There's papers to prove both, but those endpoints are always about, the comfort function looks good on an X-ray. And we're trying to think about what's going on in the tubules, because anybody can make comfort function and look good on an X-ray, but we're trying to get up this hill of dentin disinfection. So one thing that I've done for years is I mix betadine with calcium hydroxide, the povidone iodine. Calcium hydroxide you can get dry. You can get dry calcium hydroxide powder from Sultan Chemists right out of Dental Supply. Iodine is on the shelf next to glycerin in the supermarket. Betadine, Kroger brand, povidone iodine. And I take the calcium hydroxide powder and I wet it with the betadine and spin it in the canals, leave it for a week, come back, and then fill it with the endocal. Okay? Was that clear? Ozone, our new favorite thing. The ozone boys are here. A lot of us are using ozone for everything we can possibly think of. It's easy, convenient, and kills them germs pretty good. And fundamentally what I'm doing is fumigating the canals before I fill them with some oxygen and ozone. And it is very soluble, so if there's, you dry the canals and the tubules are moist, it's going to dissolve into the tubule moisture and be an additional tubule disinfectant. And then finally so what I'm saying is, if we throw everything we know at disinfecting the tubules, we're probably climbing this hill a little bit better, and we will probably end up with a higher percentage of our treated teeth being non-toxic over some period of time. And I'm quibbling a little bit because much of this is conjecture. We don't have a lot of research. Some people are researching things like this. Much of it is, on my Christmas list is a microbiology lab where we can, really investigate what's going on. It's just tragic that most of the academic establishment is not that interested in these questions. So we may or may not know. But this is my take on the subject, is basically when you have an infected root, throw the kitchen sink at the germs. And that's it. So let's talk. Once I started using the laser, I thought maybe that's going to take the place of the calcium hydroxide, and I started doing more one visit on teeth that were not overtly infected. But for the most part, I'm doing two visit on teeth that are overtly infected. In other words, preparation, laser, ozone, calcium hydroxide, iodine. Come back next week, rinse it out, laser, ozone, endocal.
Injectable Apex ozone?
Yeah, especially when there's a fistula or something like that. But yeah, injecting ozone into the apical area, that's definitely.
We've talked before, my problem with the endocal, I'm sure probably everybody who used it, is because I guess knowing you've got it in the apex, it's a very difficult system. It should be simple, but you just don't always know if you got it down there. We've talked a little bit. Do you make this up like peanut butter, or is it more like mayonnaise?
Mayonnaise. I don't think it depends on the consistency. It has to be, because it's going to harden by its own chemical process. It doesn't have to be made up extra thick. And I think it mostly has to be made up in such a way that you can manipulate it with the lentulo. Now, I don't have the slides from my original talk where I've got all the lentulo technique. There's a couple of things. You have to make a wide prep. You can't make a skinny little minimal prep in the canals. And the reason is you have to get the lentulos to the working length. So I like to make a wide prep. No, canal prep all the way down. I take that number 35, 40, 45, whatever the equivalent is in the Tulsa system. I try to get it right to the, like a little barrel-shaped prep. And I tell you what, as a parallel subject, I like to push the stuff out the apex. And the reason is, if you have a periapical lesion, you have a biofilm on the external surface of the root. And corking up to the working length is not going to affect the biofilm on the end of the root. So if you can express some calcium oxide into the periapical lesion, which requires having a... I'm making blowout preps, let me put it bluntly. Okay? I'm making blowout preps because the calcium oxide that's expressed, that's overfilled, completely biocompatible, will be carted away by the macrophages within a few months. And I've got a bunch of pictures that show overfills that are gone on follow-up x-rays. And you alkalinize and you disinfect to some extent that periapical region by doing that. You know what I'm saying? You following me? I make a big blowout prep. And then I start with a skinny lentulo. And another key is not trapping air. If you take your lentulos and you load them just to their own diameter, so you don't glob the stuff on there, and you pass it into the canal, you're not going to trap air in there. It's inconvenient because it takes multiple passes. But you load a skinny little lentulo with a little bit of endocal, just to its own diameter. You put it in, spin it in, pull it out spinning. Do it again. Do it 2 or 3 times. Then I take a bigger lentulo and go as far as it'll go freely and backfill. And they come out like, let's see. Is this slideshow still on? Something like that, Dave.
Huh? You don't need this, I don't know. And you want, oh, I didn't want that. You want this.
I want.
You want this.
Want my slideshow back.
You got it. You should like, did you shut it up?
Okay. No, really not. I mean, that's traditionally, people think that yeah, how do you get down? Oh, doing that, okay. Yeah, get the radiograph.
Where's it at?
Right there.
You mix the base real thick and use a syringe to put it in, I use the syringe here.
That one. No, I never mastered the syringe.
If you master it, if you see any, if you could do that, if you see any problems with mixing it thick, let's fix that.
No, I don't think there'd be any problem. I think if you can do it, great. It's just a matter of getting it there. But this is... that's a pretty typical result, Bill. Strictly with you know, enough of a prep to get the lentulo to the full length.
How dry are you getting your canals? You take a paper point in there? Like,
Just paper point dry.
but you make the big, but the point is dry, and you pull it out.
Yeah, it is. It is. No, you know, Bob, I don't put posts in the same day, and the reason is using endocal.
Sorry, do you want
No, not really.
There's a time issue.
Oh, there is. Okay. Well, using endocal, you need to get the patient back and take a file and poke at it to make sure that it has hardened before you proceed. And it can take as little as a couple of days, but it takes a little time. So, you know, there have been times when people were leaving for Borneo, and there was no choice. You know, you fill the canal, you restore the tooth, and they're out on a plane the next morning. But in the routine course of dentistry, you know, it's just a cost of doing business here. You get them back for a check and access or post-appointment at least a few days later. Yeah, well, then you don't do your restorative. You flush it out and put some new stuff in. And typically it doesn't set because there's persistent infection. It all has to do with pH. If the environment is restored to a neutral physiological pH, it's going to harden. If it's slightly acid, if it's 6 point something and lower, it's not going to harden. And so it's kind of a feedback system. Is that it? Anybody else have something? Greg? Yeah, EDTA will keep it from setting. EDTA will so you got to limit the EDTA exposure in your canals. I use ozone water. I don't use RC prep. I don't use. I basically don't use EDTA. Well, personally, I use EDTA if I'm exploring a calcified canal in the initial exploration phase, but I don't use it as an aid in. On the other hand, I got that stupid laser, which is blowing the tubules open anyway. So if you don't have the stupid laser, maybe you need a little EDTA to open tubules at the end of your prep. Sonny. Yeah, post space. I find it best to pre-plan the post space and dip out some calcium oxide in the initial filling. You just take a paper point and dip it out to the proper length, because sometimes it's going to harden up to the point where you cannot drill through it. So it's important to pre-plan your post space. Good point. Yes, retreatment's possible. You take that 17% EDTA and you squish it into the chamber, and you wait a couple minutes and you start picking at it. And you can dissolve it with 17% EDTA and a little elbow grease. Okay?